anybody discussed with you certain medications to try to shrink the uterus for a short period of time to see if that's improved, and if that improved from that, then obviously options of removing the uterus or certain things like that might be helpful for you. Again,
we have another good question from the audience.
Okay.
Is incontinence inevitable with diabetes, Dr. Barnes?
Not necessarily. I think the better that your diabetes is controlled, the less side effects you should have, because what happens with diabetes is that with poor sugar controls, the nerve supply to the bladder becomes damaged, and you don't have the same nerve supply that you used to have, and so you don't feel the bladder getting full like you used to. It's called a sensory neurogenic bladder, and what happens is you can't feel the bladder filling, so you don't get the same trigger to go to the bathroom. And what happens after time, if you're not emptying your bladder on a regular basis, it gets larger and larger and larger until it basically turns into a big sack of fluid that it doesn't have much contraction anymore. So that's why it's important to keep your diabetes managed as well as possible, because the same reason that you get numbness and tingling in your feet from peripheral neuropathy, that's basically the same thing that happens to the bladder. You don't get the same feeling, and so you get the numbness of the bladder, and it can get big and floppy and not as healthy as it should be. So it's not inevitable, but it can happen.
We have another question. If the reason for incontinence in women is often prolapse, what's better, surgery or pessary for a start?
Again, there are a lot of factors that go into the decision, and certainly if you have a young, healthy woman,
Yeah.
I'm sorry. There are a lot of factors that go into the decision about whether we should use conservative therapy, such as a pessary first versus surgery. And certainly someone, let's say, who actually is older and medically not a great candidate for surgery, we try conservative methods such as pessary to see if that would improve. Again, surgery doesn't seem to be something that everybody invites into their life. There can be major complications, and so it's obviously discussion between the patient and the physician as to what way they want to go. Certainly pessary is a much more conservative method and needs to be changed, although in young, healthy women, they can often change them themselves on a daily basis, and as long as they are taken well care of, they can improve incontinence and without much side effect.
Another question here from the audience about the types of pessaries. One type, of course, is to reduce prolapse into the vagina from the rectum or the bladder, but there's the difference in types that are specifically to control incontinence as well. Any comments, Dr.
The
Barnes?
pessaries that are used that we call incontinence pessaries usually have a little extra knob of plastic. If a pessary is usually a circle or a donut, the incontinence pessaries will also have an extra little ridge or an extra little support that will push up against the urethra and give extra support. I haven't had a whole lot of experience in trying to use these pessaries for incontinence itself. Usually it ends up that we use the pessaries for people with prolapse, and as a result, once you get the bladder back in the position where it's supposed to be, a lot of the times you don't need the extra support for the urethra. Just putting the bladder back up where it's supposed to be a lot of the time can be enough to where you're not having that overly active bladder. You're not getting that irritation that it has from being shoved down into the vaginal canal. So usually I don't find that I have to use the incontinence rings, but they definitely are possibilities.
I mean, the other thing about pessaries there are so many different shapes and sizes and rigidities of the pessary, and certainly people who have had hysterectomies usually require different pessaries than patients that have a uterus, that just have either uterine prolapse and or just a bladder prolapse. I mean, there are many different kinds, and they're all used for different reasons and just what fits and stays with the patient and is most comfortable. So sometimes you have to come back a few times to find which pessary is most comfortable for you and which stays in and will improve your symptoms.
Let me get one more question here from the cards, and then I'll get to you. This is a really good question because I think everybody has this on their mind. I'm 75. I only leak when I'm golfing. Is it going to get worse? You know, at what point should I think about intervening and doing something about it? Is it inevitable that incontinence that's now minimal and maybe not bothersome will get worse? And at what point should someone seek evaluation?